So I did my research evidence project on mirror therapy, and here we go.
So it is also called mirror box therapy. You can see in that picture there kind of why. Sometimes it is just a mirror. Sometimes it's an actual box that they put the limb in. It is an intervention technique that we can do in neuromuscular treatment regimes, I guess. And it is said to be simple and economical, and that's a big draw to it. Mirror box therapy or mirror therapy can reduce pain. That's its main goal, and that pain can be chronic or phantom limb pain or anything else like that. It does stimulate the brain in a non-invasive way. That's another big draw to it, and it induces a visual illusion that appears to mimic the movement of the affected limb, and that's kind of how it works, and that's what I'll get into on the next slide. So none of the research that I found said a specific age range that it should or should not be used for. Most of the time it's used with adults, but there were some articles or research done into the treatment of children with mirror box therapy or mirror therapy. I actually have a picture of a child on a later slide doing it. And it can be used to treat stroke, any general hemiparesis, which I think is where most of that children would come into play, amputations, which is what you can see in this picture down here. I actually think that's really cool, and CRPS, which we talked about in class. It is found to be most effective when used in conjunction with other intervention approaches, which I'll get into more in the evidence slide, but also it does show to have positive results in acute, subacute, and chronic phases post-stroke, but obviously early intervention or as soon as possible is best, and a lot of the research says it's key to be within 14 months of the stroke, but it is effective no matter when you do it. So how it's done, you can see the steps go through. So the mirror is placed along the mid or parasagittal plane, so it sits on the tabletop. The mirror should be large enough to reflect the entire limb chosen to do. Obviously, we would probably focus more on our arms and upper extremities. You saw the images of the legs. So obviously you need a much larger mirror for a leg. It is placed at the patient's midline. And if they have trouble seeing the mirror or they have visual field neglect, the mirror can be placed closer to them or angled to facilitate easy viewing. So then both limbs are placed on the table, one on either side of the mirror, and the mirror is placed so that the patient can see the unaffected arm or leg or whatever limb you're working with in the mirror. So the affected arm is placed so it rests comfortably on the table but remains within the box or behind the mirror. And it is important to reduce muscle tone or address any joint limitations if the limb has severe spasticity. And then the unaffected limb is placed in a position like the affected limb, but in front of the mirror reflective side. So the reflection should be clearly visible in the mirror, and you want to make sure that they remove any jewelry or anything else like that on the limb that in order to reduce distractions of the client while they're focusing on the limb. And you want to cover any obvious marks like scars or tattoos to make sure that they have like the most consistency, and you're not like, oh, I have this really ugly scar on my left arm. That's clearly two of my left arm, not my left and my right arm, because it is a big, obviously, mental practice. So that's the setup, kind of the more grit of what you're actually doing. So once they're all set, the patient needs to visualize that the reflection is the affected limb, even though it's the unaffected limb. So that kind of is what I just talked about with the jewelry and the marks and things like that. And this is a lot of where the therapist guidance comes in. So the therapist should spend some time during the first couple sessions where they do this, helping the patient to focus on the limb and the mirror and guiding them to visualize that limb as the affected limb, asking a lot of questions, facilitating the movement, everything like that. A lot of what we talked about with the external and internal feedback plays in here as well. So once the patient is comfortable visualizing the reflection as the affected limb, they can go through, and you start with simple activities, active range of motion, easy movements, things like that, and then you can grade up or down according to the patient's ability as you move through and they get more comfortable with the mirror, and as they progress in their ability, you can introduce more complex exercises and activities. You can see like the man on the bottom picture is using scissors. The child on the top picture seems to be like sorting beads or something. So those can obviously, you can upgrade, downgrade from that. You can do them in different settings. And then you can even do functional activities. Obviously not things that you need to like get up and move around to do. But like using the objects, setting up for things is big. I mean, then you see two of the things, but that's still part of the mirror. And then like I was thinking like meal prep or something would be interesting. And typically within a session or when they do it at home, you would want it to be done for 10 to 30 minutes or so at least. So while the overall underlying mechanisms for why mirror therapy works and is as effective as it is are kind of unclear, they're not 100% certain. There is a lot of theories behind it. It does provoke distinct brain activities and activation that you don't see in any other practices or intervention techniques. The big things that a lot of the research focuses on is visual feedback and mirror neurons. So the theory behind visual feedback is that the mirror stimulates the mirror neurons in the nervous system to reroute any motor signals away from the damaged motor neurons onto the motor cortex. And that rerouting kind of tricks the brain into characterizing the affected arm as quote unquote okay. And that interaction of the visual feedback and the mirror neurons in the brain makes the brain forget that the affected limb has pain or limited movement or maybe isn't even there. And that's kind of what makes it effective to treat the affected arm. And your brain thinks of it the same as the unaffected arm. So I did mention some of those mirror neurons. I know we may have learned about them in various psych classes, but they are neurons in the brain that are activated when you perform a task, and they're activated in the contralateral hemisphere via visual feedback. So if I'm doing something with my left arm, they're in my right hemisphere, and they're also activated not only when you're doing something, but when you're watching someone else perform a task. But they are only activated when you watch an action that you yourself can perform. So if I'm watching someone do a backflip, my mirror neurons are not going because I can't do that. But they are also activated when a person is imagining an action and not only performing it. Like if I'm imagining myself going through a dance routine, my mirror neurons would be going off because that's something that I know how to do. And then it's also why you can sometimes feel what other people are feeling. So like if I slam my arm on a door and I hit my funny bone, someone else is probably going to wince because they kind of feel it. And that's kind of that visualization piece that ties into mirror therapy. And the firing of the mirror neurons works to unmask and sprout neural pathways in the brain for the performed movements that you visualize, do, or see. The neuroplasticity piece, you're obviously increasing communication within the brain, and you're normalizing asymmetric electric activities and activating specific areas in the brain that may not otherwise be able to be activated or accessed depending on the level of involvement or impairment in that affected limb. And then that last bullet, you'll see I have that it induces movement and perception. And by that, I mean that kind of different brain hemispheres, contralateral to the moving limb, exhibit activation in their primary motor cortex. So that induces a lot of brain activity. There's a lot of muscle activity within the inactive limb that you don't get a lot of other times because the brain isn't treating it as it normally does. It's really treating it as it does the unaffected limb. And so you see a lot of like different movements that you wouldn't necessarily have seen otherwise in that limb and that the person can't necessarily do volitionally when they're thinking of moving that affected limb. And then also the visual illusion of normal pain-free movement results in cortical reorganization of the homunculus, which is where pain comes from or is like organized or whatever. So that in itself reduces pain. And it can correct the mismatch between the motor control, proprioception, and vision. And then it works on a lot of different brain areas. I've talked about a few already, but it also, so like the motor cortex and everything, the premotor cortex, the primary motor cortex, the somatosensory cortex, it works in the cerebellum, the corpus callosum to kind of get that crosstalk, more talk, communication, things like that. It talks a lot about the dorsal frontal area as well as the occipital lobe, obviously, because we are talking about that visual feedback and visual integration. So I did mention in a previous slide that it is a non-invasive intervention and treatment technique, but I did come across and think of some side effects that can still be elicited or caused by mirror therapy in general. And the big things that the research says is the client may react emotionally to many different things, and that could be like the thought of seeing that affected arm or limb intact if it's injured or broken, or not broken specifically, but has an injury or anything like that. It can stir up thoughts, especially very emotional thoughts of loss after an amputation, or like that, I'm not normal, I'm never going to be normal, things like that. And then the reflection the reflection in the mirror of pain-free movement can cause them to reflect on times when they had no pain, or the experience that they've had due to pain, or how it's altered their life or anything like that. So that's kind of another aspect that as OTs that we are so holistic we have to think of. We're not just treating them physically, we also want to think of that psychosocial aspect as well. And they can also have some like physiological side effects when viewing the image, just because it is a mirror. I don't know if you've ever looked in a mirror for too long, but it can kind of make you dizzy or nauseous. It can cause headaches in clients, things like that. The positioning may be uncomfortable, so they may get sore, things like that.
I also just want to say too, I love this like top image of the two amputees or prosthetics with the mirror therapy in the lower extremity. I just think it's really cool.
So up until about 2011, there was very little evidence or research done into mirror therapy. So it is, by all accounts, kind of a newer, backed by science treatment or intervention technique, I guess. And I'm not going to read through all of these, but you can definitely look at them. These are kind of like the big, like, groundbreakers in neurotherapy evidence and research, I guess. They're kind of the first few to do it. And you can see that they found a lot of different things, moderate effect on improving motor function, quality of evidence for improving arm function after a stroke. You will see like this Mahantni one talks about how it is good in conventional therapy, or in addition to conventional therapy, which I talked about in the previous slide. The Brondock one too, when used as an adjunct technique to task-oriented training, provides meaningful improvement to motor function. And then this last one even talks about improvement in tactile sensation, which is also something we talked about a lot in the past few weeks, and techniques that we talked about in class, with how sensation really is a big aspect or component to motor function and your ability to move. So I thought of some limitations, or I have biases. I don't know if there are any that really would be considered a bias in this situation. But nonetheless, I thought through some of these, and on the slide I have like the basic groupings that I have of them. So for cognition, I thought, they need, and this is some of my thoughts, but also some of what the evidence and the research has said. You can see I have 2 citations down the bottom. But for cognition, they need enough cognition to be able to follow instructions of the therapist and to carry out the tasks. They need some level of cognition to understand the intervention technique in itself, not just like, hey, what the heck is this mirror doing here? And they need to be able to attend not only to the limb in the mirror for at least 10 minutes, but also to attend to the presence of the mirror, as it can be like a barrier. And they also need to be able to keep it behind the mirror, which can be something if they don't understand, like if they don't have the cognitive awareness of what you're doing, they just kind of pull that arm in.
That could also be something like a physical limitation or bias if they have too much tone, like they're all the way in here and they can't get it positioned all the way out. That could limit the ability of them to be able to use mirror therapy as a technique.
Or kind of hit it or whatever. For vision, they said like they need to have enough functional vision to be able to see the reflection of the unaffected limb in the mirror, and they need to be able to compensate by turning the head if they do have visual field neglect, which also kind of ties back into the cognitive aspect. For muscular limitations or control limitations, they need enough postural control to sit independently. If they're doing the arm in the wheelchair or a regular chair, if you're doing like a lower extremity, maybe on that mat table or anything like that. The unaffected limb should have enough pain-free functional range of motion to allow full participation in therapeutic exercise and activity. So it'd be kind of hard to do mirror therapy on someone who has involvement on both sides. So like Grace and I have both worked with Angela, and she probably wouldn't be the best candidate for this because her quote unquote better side is still very involved. And that wouldn't necessarily be the best goal to work towards or in mirror therapy at least. And then this is right from an article. So it says that mirror therapy only allows for small movements. So granted, you can see like the mirror is kind of small. It doesn't have to be isolated just to the finger, but you're not going to work on like big shoulder movements because that kind of moves the arm out of the mirror's reflection. And it cannot provide a truly realistic experience to fool the brain and give it an illusion of movement in those larger movements. And then some authors actually discuss virtual reality as a possible alternative to mirror therapy, which is definitely something that I thought about when we were doing that virtual reality experience, and it was kind of reminding me of mirror therapy in a way. For compliance, they should be able to incorporate mirror therapy into their daily to be most effective. So they need to comply to the therapy schedule. Their allotted number of visits may be a bias. So if they don't have a whole lot, or they don't have the best health insurance or whatever, kind of tying into policy, because all of our classes are connected, if we forget that, that can be something that discriminates against the better use of this therapy. But they also have to, or they don't have to, but it's best if they are able to comply to a home program, or they're willing to comply to the home program. So motivation is a key to that. And I think one of our research groups, or one of Dr. Kunish's research proposals at least, talked about the compliance of the home program in mirror therapy. The last little section I have is the injury itself. So I thought specifically the stroke, so the density of that stroke or the damage to the upper extremity function can really be a limitation to what you can do. Kind of like what we talked about CIMT there, like I feel like you do need some like movement within it to try, but not necessarily. But the worse damage, or the more severe of the damage or the affected area or the pathways in the brain, can really limit or change how effective mirror therapy will be and how much work it's going to be for it to work. As it is, like we talked about, harder to regenerate or like work on unmask, sprout new pathways as there is more damage and more density within that brain. So then to finish off, I have my forum questions. So my first would be, how do you think various cognitive impairments could affect an individual's ability to partake in and or benefit from mirror therapy? What other conditions or diagnoses could you see mirror therapy being used to treat? And are there any like specific in pediatrics that you could think of? And then my last one is, can you think of any other possible side effects of mirror therapy as an intervention that can be adverse or beneficial? Maybe there's like an added extra thing that you get from mirror therapy other than just that affected limb getting stimulation in the brain. But on top of that, how would you go about treating some of those more emotional aspects of the treatment that I talked about in that slide? And could that ever be an indication not to do mirror therapy?
And then those are my references. Thanks, guys.